Exercise, also referred to in lecture as physical activity or PA. First, we need to know the operational definition of the recommended amount of exercise. From the American College of Sports Medicine and the American Heart Association in 2007, moderate intensity cardio or aerobic exercise for at least 30 minutes on 5 or more days per week, or vigorous intensity cardio or aerobic exercise for at least 20 minutes on 3 or more days per week. 2/3 of American adults do not achieve recommended levels of physical activity, and about 40% of American adults do not engage in any leisure time physical activity. Only 15% of Canadian adults get recommended amount of physical activity, at least 150 minutes of moderate to vigorous physical activity a week. One of the most prominent decreases in physical activity is between the ages of 25 and 35. In 2012, at least 49% of over 90,000 college students surveyed did not meet national guidelines for exercise. By the age of 80, the amount of additional life attributable to aerobic exercise is between 1 and 2 years. It is also true that to achieve those extra 2 years, a person will have devoted an entire 2 years to exercise over their lifetime. Determinants of regular exercise. On average, only half of those who initiate a voluntary exercise program are still participating in that program after 6 months. In other words, 6-month participation levels range from 11 to 87%, averaging about 50%. The best predictor of current exercise is past exercise. From an early age, boys get more exercise than girls. Adolescents affiliate with peers who show similar levels of physical activity. Affiliating with a particular crowd is also associated with exercise. Those who affiliated with a jock or popular group exercised more. Peers also influence college students' exercise, though there is less research in this age group. In young adulthood, increases in exercise are associated with decreased frequency of substance abuse. Adults with depressive symptoms have lower exercise levels, and those with depressive symptoms who initiate regular exercise are more likely to discontinue it. People, mostly women in this sample, with higher depressive symptoms reported lower self-efficacy on days they did not exercise than those with lower depressive symptoms. Middle-aged and older women are especially unlikely to get exercise. This is not due to negative attitudes toward exercise, but to practical barriers and social attitudes that discourage exercise in this population. Parenthood and physical activity. Retrospective research found over 50% of previously active women at public health guideline levels are no longer active 5 years into motherhood. Longitudinal research on Australian mothers found that they were about 2 times more likely to be inactive compared to non-mothers 4 years after the onset of motherhood. Fathers also experienced similar or even greater declines, although most research has focused on mothers. The problem: most research on parenthood and physical activity has been retrospective self-report. Prince in 2008 noted that parents may consider their pre-parenthood life through rose-colored glasses, meaning that they report higher than actual pre-parenthood activity means more of a decline is found. Accelerometry addresses this problem by a monitor attached to an elastic belt worn at the waist. Rhodes in 2014 found that first and second time Canadian moms showed significantly lower perceived behavioral control at 12 months, whether they were confident they could be physically active and whether they were motivated, than non-mothers. Note, this is not a generalizable sample, as they were more educated, less overweight, and more active than the average for the Canadian population. Cultural variations in physical activity. Minority groups have lower rates than majority groups in the U.S. Minority women are among the least active subgroups in the U.S. Physical activity is also lower among those with low incomes and lower levels of education. The following are correlated with getting involved in an exercise program. Coming from a family where exercise is practiced. Having positive attitudes toward physical activity. Perceiving oneself as athletic or the type of person who exercises. Believing individuals should take responsibility for their health. But these factors do not predict participation over the long term. Those who have a positive attitude toward exercise and health are as likely to drop out as those who do not. Overweight individuals are less likely to participate in exercise programs. Those at risk for cardiovascular disease do show greater adherence, but otherwise no general correlation between health status and exercise can be found. Self-efficacy is the feeling of competence. A study with sedentary middle-aged adults found that those with high self-efficacy with respect to exercise reported more positive affect during exercise and perceived themselves to expend less effort. Characteristics of setting. Convenient and easily accessible exercise setting led to higher rates of adherence. There appears to be no ideal behavioral dosage that improves adherence, i.e., a particular amount of exercise prescribed to them. The first 3 to 6 months appear critical. Those who drop out tend to do so in that period. Those who have adhered that long are more likely to continue exercising. Characteristics of intervention strategies. When exercise is made more convenient, for example in home or near work or your home, and when tied to one's social system, adherence is higher. Marlett and Gordon's relapse prevention approach has been used to increase adherence to exercise programs. A comparison was conducted of subjects in a 10-week exercise group that either did or did not receive this training. Prevention techniques included increasing awareness of obstacles and developing ways to cope with them. There was superior adherence in the relapse prevention group. Cardiovascular benefits of exercise. In the early 20th century, physicians advised patients with heart disease to avoid strenuous physical activity.